So let's pivot to the imaging study you did. So now we're looking, same cohort of patients, but seeing how that circulating tumor DNA correlates to progression on imaging, correct? So what was your rationale behind that? What was your objective in looking at it in a slightly different way?
So if you look at the current AUA guidelines for imaging after partial radical nephrectomy according to the different risk groups, so we have the low, intermediate, high risk, and the very high risk, which is really informed from the grade of the tumor and the stage.
Sure.
So if you look there, you can see that AUA recommends surveillance for 10 years. So the very high risk will need a CT scan, about 12 of those. The low risk will need 6 CT or MRI scans throughout this period of follow-up. And the question is, like, this is radiation toxicity and this is contrast toxicity, and some of these patients had surgery, so their kidney function is already impaired in some way. So the question is, are we able to use ctDNA to kind of relax? So if it's undetectable, can we relax the surveillance guidelines, meaning you do a CT scan once a year and then a ctDNA every 3 months?
So I might argue
that's another option.
Absolutely, and I might argue also that financial toxicity is a huge consideration there as well, especially in patients who are talking with incidentally found smaller renal masses. These patients are going to live a long time, and the likelihood of recurrence is relatively low in a lot of these patients, yet we're still scanning them probably way more than we need to, and that requires time off from work for a lot of them, traveling, all the expenses that go with that, parking. So a huge impact on not only their radiation exposure, but also their pocketbook and how they might interact with the healthcare system moving forward. So summarize to me what you found in that study with imaging.
So we found that out of 50 patients that we could really compare their CT scans or MRI scans and the ctDNA, so they had like a corresponding analysis. So we found that practically 41 patients had undetectable ctDNA, and they had no findings on the imaging study, and really the outcome of these patients was no recurrence. We had 4 patients who developed metastatic disease, and all of them had detectable ctDNA before. So this was fully correlated. The other cohort of patients, which is not very large, it's only 5 patients, with suspicious findings on the imaging studies. Their ctDNA was negative, so undetectable, and their outcome on corresponding ctDNA scans was no metastatic development. So actually the CT scans showed equivocal findings which did not translate into metastatic disease. Again, this is very preliminary and exploratory, but we can say exactly add to what you were saying, that there is some financial toxicity also from the scans and from the assays.
Sure.
The question is, and I guess this will follow in the future to make some kind of financial analysis, what will be better.
Yeah.
I'm not confident that the ctDNA assays will be much more expensive than doing a CT scan every 3 months.
Yeah.
So this is something that I'm not fully aware of the actual pricing, but it might end up that the most expensive part in the ctDNA analysis is the first part, making the tumor signature, and then collecting the blood and just checking if ctDNA is detected or not. I guess it's not as expensive as a CT scan or MRI scan. But again, this is not something we specifically examined in this, this study.
I mean, it's super exciting though. I mean, I think ctDNA, we're seeing its uptake in a lot of different GU oncology spaces. I think it makes sense that renal cell carcinoma, would there be a signal there and a use for it there? Really, really exciting work. Just sum up for us, what do you think is next here, and what are your plans in looking at this further in this disease space?
So for us, ctDNA was detectable in 60% of localized RCC, which is great results if we compare to other agnostic assays that we used in the past. So that's one thing. So ctDNA gives us additional information for RCC. That's one thing for the localized stage. The other thing is that the MRD ctDNA window really correlates with metastatic progression in the patients. The next thing will be the relaxation of imaging studies with clinical trials. We can use ctDNA maybe to relax the imaging studies. And finally, all this needs to be summarized in some kind of a clinical trial, maybe looking at ctDNA and informing our decisions from the ctDNA status, from the pathological characteristics of the patients, and really deciding who should get adjuvant, who should not get adjuvant, who should be scanned every 3 months, who should not be scanned every 3 months, really adding that additional personalized medicine feel to the patients. Because, I mean, this is eventually what we care about our patients. We don't want them to be scanned unnecessarily. We don't want them to get unnecessary immunotherapy. And if this can help us to do it, this is my aim in these studies.